Okay, I think we're at the top of the hour, so we're going to go ahead and get started. Welcome everyone to our coffee chat today on addressing cognitive impairment in medical respite care. My name is Julia Dobbins. I'm a project manager here at the National Healthcare for the Homeless Council. This is the first of 2 coffee chats hosted by the RCPN this year, and we call them coffee chats because these are informal conversations, and we encourage you to grab a cup of coffee, grab your lunch, and listen and discuss. So this is really an opportunity for us to share questions, ideas, and challenges, and really to support each other in this work that we're doing. One of the best parts of the coffee chat is getting a chance to hear from people who are doing similar work across the country. So I really encourage you to ask questions and engage in our hour together today. So this coffee chat today is hosted by the Respite Care Providers Network. The network helps members connect, learn from each other, and share best practices in the development and delivery of medical respite services. I assume, since you're joining this coffee chat today, that you're familiar with medical respite care, or recuperative care as it's sometimes referred to. Quick shout out to our friends in California. But for those of you who are not familiar, just to get us on the same page, we define medical respite care as acute and post-acute care for people who are homeless, who are too ill or frail to recover from an illness or injury on the street or in shelter, but who are not technically sick enough to require hospital-level care. So medical respite is really short-term residential care that allows people who are homeless a safe place to rest and recover while also receiving access to medical care and wraparound services. If you are not already a member of the RCPN, I encourage you to join today. It's free. You can join by visiting our website at nhchc.org/join. So just some few brief instructions on how to engage during the chat today. We really want to hear from you. We want to welcome your questions and experiences and stories throughout the chat. Truthfully, the more you engage, the better this chat will be. So you can just enter your comments and questions into the attendee chat box down at the bottom of your screen. All of the participants can see your comments and questions, and I will try to refer your comments and questions to the panelists as they come in. So to begin today, we want to get to know who we have in the room. We want to hear a little bit about who you are. So we're going to do a few poll questions. Caroline, if you could bring up the first poll question. We want to know what type of organization you represent. So you can let us know if you're working in a respite program currently, if you work for a Healthcare for the Homeless program, other nonprofits. Let's see here. You might be in the process of developing a respite program too. Okay. Great. So it looks like we have a mix, a lot of health center representatives here and a few nonprofits. Great. Thank you. So we'll go ahead and move to the next poll. So now that we know where you're working, we want to hear a little bit about what your role is in your work. So our next poll question is, what is your current role at your organization? Are you doing hands-on care? Are you administrator? Do you have any consumer representatives today? Great. And if you clicked other, it'd be interesting to hear what your role is. So please feel free to share that in the chat pod. Great. Thanks, guys. We've got a good spread of clinicians and administrators. Okay, let's move to the last question. So we're spending time today talking about cognitive impairment and treating folks with cognitive impairment in respite. And so we want to get a sense of what your level of comfort is treating patients who are struggling with cognitive impairment issues. Some folks might be very new to this. Some folks might be seasoned veterans. I'm guessing we'll bring a lot of different experience to it. Great, Laura, data management. Great, glad to have you. Awesome. Okay. Perfect. Thanks, guys. Thank you, Caroline. You can go ahead and close the poll. It's really helpful for us to get a sense of who's in the room, so I appreciate that. Before I introduce our panelists, I just want to point out a few relevant resources that we have. If you look at the resources pod at the bottom of your screen, the first document in there is a resource developed by our panelists on cognitive impairment in medical respite care, in medical respite programs. And then the second resource was developed by the RCPN and the Council, and that is the standards for medical respite care. So both relevant resources to our conversation today. So now I am thrilled to introduce our two panelists, both of them joining us from Baltimore, Maryland, both of them occupational therapists. We have Caitlin Sinovec and Mara Snyder joining us today. Welcome. Thank you for being here. I'm going to turn it over to you to share a little bit more about who you are and then share some slides with us. So guys, take it away.
Okay, good afternoon, everybody. So we are both occupational therapists at the HCH in Baltimore, and we both overall have practice experience working with individuals with mental health diagnoses, and then transitioning here to healthcare for the homeless, really addressing everything that a client might present with, as our clients tend to do, with a really strong emphasis and focus on cognition, as we found that that was sort of an unaddressed, untapped area for our clients here, and so that's a lot of what we've done over the past couple of years. So, do you have anything to add? No, that's it at all. There we go. We're very similar. Okay.
So to start off, we wanted to give a brief overview of what cognition really is. So this slide really just provides the definition. So cognition is information processing functions carried out by the brain that include attention, memory, executive functions, comprehension, and formation of speech, calculation ability, visual perception, and praxis skills. Functional cognition is really the ability to use and integrate thinking and performance skills to accomplish complex everyday activities. So Caitlin's going to go into a little bit about what that actually will look like.
And so for our clients, there's a lot of different causes of why someone might have cognitive impairment. There can be organic, more medical causes, such as brain injury, long-standing developmental or learning disabilities. HIV over time can certainly address or impact somebody's cognition. Same thing with substance use. So there's under the influence, there's sort of the temporary impact on cognition, but for someone who's been using for a long time, there's going to be this long-term effect on cognitive skills. Serious mental illness, and this will change depending on the acuity of someone's illness. So if someone's in a depressive episode, we can assume their cognition is impacted more than maybe when they're not. However, people who have diagnoses such as schizophrenia or anxiety might have just sort of this ongoing cognitive impairment that we can see impacting function. And then there's things like encephalopathies and dementia, other things that maybe are going to impact cognition. They're happening sort of organically in the brain. And then environmentally, things like poor nutrition, sleep deprivation, and a history of trauma or ongoing trauma and stress can impact cognition. And really that when we think about this in our clients, I don't know about you guys, but I feel like every single one of my clients, I could check more than one box on here, especially the environmental considerations. And so even if someone's functioning and managing their mental health fairly well, because of the environments that they're living in, they're going to maybe have some impact on cognition because of just the ongoing stress or the inability to address trauma because it's not safe. And so those are things I think that we at baseline should always be considering just for that reason. Oh, this is mine. Okay. And so when we think about what cognitive impairment might impact, so Mara talked about the different things that make up cognition, such as concentration, attention, memory. Those we're familiar with. What we might see that looking like, especially in regards to health management, and it can affect all types of areas of function. We're going to focus on health management here just because that's often what is the focus of a respite care stay. But thinking about remembering dosing instructions and medication changes, being able to problem solve or anticipate when there might be a problem for something, or what happens if, what do I do if something that I wasn't prepared for occurs? Can I solve it, or do I just abandon the task? Just simply remembering to take medication on time, especially if someone is in an acute illness, taking a medication such as an antibiotic, which might have multiple doses throughout the day, or the schedule might change, and is not within someone's routine, that can be really problematic. And then just really in general, sequencing many steps at a time and remembering what they did. So we see this a lot, for example, with checking blood sugars with a glucometer. Learning that for people with cognitive impairment can be really difficult because there's about 10 steps really that go into being able to do that.
In addition, one of the things to also remember is that if a client is coming into a respite care environment, there might have been a big change in the familiarity or in their familiarity with what their procedure is. So that's another thing where someone might say that they're doing okay with all of their medications, but now that they're in a respite environment, their medications may have changed, and then the cognitive impairments might come out a little bit more acutely.
Yeah, or any sort of really new, thinking of people managing prostheses, like after having an amputation, that's a very big change and something really new to manage in terms of wound care and putting on the prosthetic and, again, the medications that go with that. So that can, Mara has a great point in bringing up that, people are dealing with new things that maybe otherwise they've been able to manage their health prior to coming in. And so in terms of screening and assessing for cognition, these are just 3 examples. There's a ton of different cognitive assessments that exist in the world and are going to look at different components of cognition because it is so complex. These are 3 basic screens that are available to most providers and clinicians. We very commonly use the Montreal Cognitive Assessment here at our clinic, the MOCA, which assesses a lot of those skills that we talked about: memory, visual spatial skills, executive functioning, attention, and language, all of those things. The MOCA used to be free, and then someone administered it on the president, and after that they decided that it cannot be freely available anymore. So you do have to pay to do a training to be able to use the MOCA now. But once you have completed the training, you can access all of their resources for free, print out and download their score form for free. So it is a pretty accessible tool, and there's like group training options available if that was something to be adopted by the site. And then there's also the St. Louis Mental Status Exam, known as the SLUMS. This one is pretty comparable to the MOCA. It generally tends to be a location and provider preference as to which one you use. So it's going to assess a lot of the same components. It is offered for free. You don't have to sign up, or you're not required to do a training to do it, but the website does offer training for if you're unfamiliar with it. And so both of these really should be administered by a provider of some type, a medical provider. And then there's the mini mental status exam, which is what most people are familiar with. It's a really quick assessment, but it's most accurate when you're looking for dementia and delirium. It is not as sensitive as the SLUMS or the MOCA, which are both screens as well. And so people may do well on the mini mental status exam and yet have cognitive impairment. So it might not be able to identify as comprehensively some of these other issues. If someone's more acute, if you're monitoring delirium, like if someone's getting ECT treatment, then that mini mental is most appropriate. But it can also be a good place to start because people are so familiar with it. So we wanted to stop here just to see if there were any questions specifically regarding screening and assessment of cognition.
I have a quick question. Do you use all 3 of these at Baltimore?
We mostly use the Montreal Cognitive Assessment. I think some of our primary care providers do administer the mini mental status exam, especially if someone's presenting differently than they might normally present, and so they'll use it and document it. But we mostly just use the MOCA, and I think that's just sort of with our familiarity and preference. But you could certainly use the SLUMS as well. You just want to, there's not a benefit to using both. You kind of want to pick one or the other. So, and it seems to be helpful to just pick one and sort of have all providers become aware and familiar with it, because now we've done it so frequently with our clients that even providers who aren't trained to administer it understand what the scoring is and what that might mean and how that might impact care. So that's really helpful if you're consistent with what you're using for kind of everyone to understand what it means when someone gets an 18 on the MOCA and how that might impact them.
Yeah, so for like all levels of staff to understand what that means, regardless of, you know, what level of care they're providing.
Yeah, and mostly our clinical staff. We haven't done, like, you know, like frontline staff haven't necessarily. We kind of use more layman's terms with that. But, yeah, any of the clinical staff, social workers, primary care, nursing, case management, that type of thing.
I think it also, if you're using the same assessment, it actually really helps too if, let's say, one of us were to leave or a client is no longer seeing OT but is seeing a social worker. Since a social worker is able to give the same assessment, they're able to kind of continue that process to see if there's been any big or significant changes in cognition.
Yeah. So both the MOCA and the SLUMS can be re-administered. Usually recommended like not earlier than 3 or 6 months. There's some clients who we kind of do it yearly just to assess for a progression and change. And that's especially like for people with ongoing substance use or HIV, things where there's a high risk of deterioration, then we might do it. But it's nice because then you can, there's like a measurable score to say, okay, well, they got 24 this time and now they're at a 20. Something's happening. Let's investigate what's happening further.
One more question. Is this administered to people upon admission? Is this across the board, or is it depending on the client or who's working with the client?
At the respite care, we generally do it based on recommendation of the providers there when they notice some of these sort of red flags for cognitive impairment. We also try to administer it on all seniors because there is a higher risk of cognitive impairment over 65. And so anyone, I think we kind of do 60 and over because our population ages faster. And so that's who we generally try to catch, is all seniors regardless of what they're presenting, and then definitely people who are demonstrating difficulties that could be cognitive impairment.
Great. Thank you.
Making sure there's no questions. But we can always come back to assessment later on too when we get through this more didactic piece.
So Caitlin mentioned that both of us have experience with mental health, OT in our background, and when we came to healthcare for the homeless, our tasks were changed a little bit based on the population that we serve and the fact that they have a lot of additional complications or diagnoses that might complicate simple, focusing on behavioral health symptoms. So the things that we do here, we look at functional assessment, so how the person is able to interact within kind of their day-to-day tasks and what their needs are. Cognitive screening, which we just talked about, typically for us that's using the MOCA. Client interview and building rapport, particularly with our clients because they don't often have a great experience with healthcare providers. There's also the intervention, which I can talk a little bit more about in just a second, home safety assessments, and consultations. So Caitlin and I see clients from all the different departments that we see or that we have here at Healthcare for the Homeless, including behavioral health, where we're often working with clients for things like coping skills, management of any kind of mental health diagnosis. A lot of times we work with them on community integration. We also see clients who are referred from medical. So oftentimes if a client has had a fall, presents with impaired cognition or has a really hard time remembering anything with their medication, if they're confused about time, date, they're having a hard time understanding their new medications or any kind of information that might be coming their way. And we also work with our supportive housing and case management teams, typically on housing as well as independent living skills. And a lot of times based on familiarity with clients or how engaged they've been in any of these areas of our practice, and or if they've been seen by kind of everyone throughout the line. Oftentimes we get clients referred from multiple places at once because a lot of times with the cognitive deficits, you're seeing that something's not quite right, but you don't always know what that is.
And I see a question about what functional assessment tools that we use. So because we are OTs, we use OT-specific functional assessment tools. One's called the executive function, what is it? Performance test, there we go. It's like I can think of the acronym, not the full thing. Or the assessment of motor and process skills, or more specific functional assessments, like there's one specifically for medication management or time management. So those are ones that are sort of specific to the OT realm. There is it's called the WHODAS 2.0, the World Health Organization Disability Assessment Scale, I think. If you Google WHODAS 2.0, it will come up. But that one is a global functional assessment that can be administered by any provider, and it can be administered with the client, so they're giving a self-report about how they feel they're impacted by different areas of daily functioning, including, I think, ADLs, communication and social skills, like ability to get around in the community, that. And it can also, there's an option for someone to answer on behalf of the client in the case there may be a caregiver, or you could do it based on your observation of the client, especially in respite care because you're seeing people a lot more frequently than you might in the traditional clinic. That one isn't formally used here. We did it as part of a pilot training, but because there's OT here and then other grants and screenings that we do, it's not one that's regularly administered by other providers. But we have tried it to give feedback on it. All right. And so then looking specifically at occupational therapy and respite care, Mara went over what we do very broadly at Healthcare for the Homeless. And so a lot of what we do at respite care is similar in terms of doing the functional and cognitive assessments like we talked about. And then our interventions are very specific a lot of times to health and self-management because that's often why the client is at respite care. And because they're there for a shorter duration of time, we may work with clients in the regular clinic for 6 months, say, to really develop these skills, but individuals are not at respite care that long. And so we sort of focus in and intensify on certain skills while they're there, whether it be 2 weeks, 4 weeks, that type of thing. And so the interventions we look at there are a lot about medication management skills, like Mara said. Falls prevention is another big thing that we're looking at, again, with people addressing new physical limitations, and they may not be able to problem solve how to get around in the same way that they used to be able to. They might not have gotten great transfer training. Or the environment's very different, set up differently in respite programs in the community than it is in the hospital. They're not as accessible. And so that's a big part of what we can address. And then just self-organizational and memory skills, developing strategies to keep track of appointments, keep track of paperwork, keep track of personal belongings. The person that's losing their phone every other day and getting really frustrated by that, helping them develop some strategies to be able to take care of those things, and hopefully that will then assist in taking care of their health even when they're not in the respite care program, getting some of that more intensive support of a community health worker or a nurse to say, hey, did you take your meds? Hey, did you remember this appointment today? We want people to be able to do those things on their own later. And then sometimes based on assessment, we might make a recommendation to what level of care someone needs following their time at respite care, if someone needs to be engaged with a community health worker, if available in the clinic setting, or nursing adherence, or anything like that. That can be a recommendation that we give. So that is our quick and dirty spiel, and now I think we open it up for just chat and questions.
Yeah, thank you so much. That would be great. So any participants, if you have questions or comments, stories of patients that you have worked with that you want to share, that would be great. Please put them in the chat pod at the bottom of your screen. I'll get us started with a question while people are thinking and typing. So I'm interested to hear from you about supporting and empowering staff who are responding to maybe behavioral outbursts that might be related to some cognitive impairment. If you could talk a little bit about some of the behavioral pieces and how respite programs can respond to that in a functional way and hopefully without having to exit people from the program.
Yeah, I think there's sort of two approaches to that. One is prevention, like preventing these situations that might be escalating or triggering to clients, and then also having good awareness in response to that. And so I guess in terms of in-the-moment de-escalation and the frontline staff, I think it's a lot of education on what cognitive impairment, what brain injury might be, what are realistic expectations of the client, and it's using a lot of trauma-informed approaches and typical de-escalation strategies, right? Like being careful of your language and your, how close you are to the person and giving directive prompts, things like that work well with the population because it's direct, it's very clear as to what they are supposed to do and not supposed to do. So doing that and just reminding clinicians over and over, especially with the more difficult clients or people with memory issues, that it's not volitional. People aren't not doing these things on purpose. They're, just to be difficult or intentionally to upset the person. That they're in some cases where they really aren't able to remember or they aren't able to do it. And so just reminding people and sort of, how do you as a provider have patience with that? How are you going to calm yourself to be able to help this person, even if you have to answer the same question, every single day or 3 or 4 times a day? Because that frustration, people can perceive that even if they have cognitive impairment, and that by itself can be escalating.
I do also think sometimes if we can put an emphasis on screening, a lot of times because these behaviors seem like they could be volitional or they could be something that a person is better able to manage, we tend to get frustrated ourselves as providers and then don't take the time to take a step back and realize that this might be outside of the person's control and it might be a symptom of cognition. So by increasing our screening and really advocating for people to be a little bit more aware of what the symptoms of decreased cognition or even brain injury would look like, that way you start to foster the conversation where people are not going to be jumping to the gun and getting frustrated themselves.
Mm-hmm. Great.
Yeah, and then in terms of, I think, prevention and setting up the environment, like sort of enabling everyone from the get-go and not necessarily calling specific people out, like, oh, you have a cognitive impairment, you need a calendar, right? Setting up the environment so that everyone has a calendar to write down their appointments, because most of us need that. Sort of facilitating and being very clear about what the rules are and what the expectations are. Having clearly posted signs that people can sort of self-identify what these things might be. Being consistent with what the rules are. I think that's where a lot of problems have come from, even just within our location, is if there's different staff working at different times of day. We have shelter staff and then we have HCH staff on the floor, and so if the shelter staff are giving different information than what our staff might be giving, that can be really confusing to people who have trouble keeping up with that anyways, and then very frustrating. So making sure everyone is consistent with applying the rules, applying the standards of things, all of that can sort of prevent some of the behavior issues that might come up. And I think just allowing people the time, people get very frustrated when they don't understand, and so taking the time to meet with people individually in a quiet space to sort of give instructions or talk about something so that they can approach a situation comfortably instead of sort of shouting across the room like, hey, you were supposed to be at your appointment today, why aren't you leaving yet? That can be triggering to a client who maybe didn't remember that it was supposed to happen. It's frustrated because they're unsure, they're unprepared, they feel embarrassed. All of that could be managed by taking the person aside quietly and saying, hey, like, you have your appointment today. Do you need help getting there? Do you remember what this is for? And helping them feel more prepared for that.
Great. That's great. Questions from the group? Questions or comments?
Or scenarios. Anyone has a client that they want the group to sort of say, hey, what would you do? Or any success stories that you'd want to share.
while people are thinking about that and typing, you said a little bit about de-escalation training. What other training do you think is good for staff? So trauma-informed care, obviously, de-escalation. What else do you think would be helpful for respite staff?
I think for clinical staff, you can get more into the nitty-gritty about cognition and what cognition is and what it might look like and strategies that you can do. And I think for maybe more frontline or less clinical staff, like sort of just, again, a basic education. And I think for everyone, just because it's good for all of us, like that self-care to manage the frustration, because it's hard to deal with people who are difficult sometimes, and it's hard to repeat yourself over and over again until like someone's not listening. And so acknowledging that that's okay to feel frustrated with someone and dealing with those feelings to be able to help ourselves with that.
Mm-hmm. Great. Thank you. Annie, I see you typing.
And I will plug that the National Council has guidelines for traumatic brain injury that are available now, and those guidelines include, it's a very comprehensive document, but it includes a lot of information about dealing with cognitive impairment. So looking at really specific strategies there, your program can look at kind of adapting your practice. Those guidelines are really, really helpful and available for free on the website. Free is always good.
Yeah. Thank you for plugging the council's website. I have a list of questions I'm happy to ask, but I want to make sure that there's room for our attendees to ask questions and share what's happening in their programs or maybe something that they're struggling with. So I encourage you to jump in with questions or stories of clients that you've had in your respite program. I wanted to ask this is a challenging one, but how have you guys navigated issues around capacity or autonomy and really clients who are where you have to move into issues relating to guardianship of people, determining that people don't have the cognition level to make decisions for themselves, and how do you approach that and move through that with their care?
we're both thinking of clients that we're like, oh, that was so hard.
Just keeping it real low-key.
I mean, I think the first thing is that it's tricky from the community perspective to be pursuing guardianship for people. I think that's the experience that we've had, at least here in Maryland. We can contribute to some of that decision-making. So if you do a cognitive assessment on someone and they score really, really low, and there is concern about capacity for decision-making, to us that's a red flag for referral for maybe a neuropsych evaluation, because those here at least are pretty hard to come by, and so we try to sort of prioritize who we put our resources into getting those and fast-tracking it that way. Because the neuropsych assessment is going to delve a lot more into some of these cognitive issues than a basic screening will. And so that can give a good picture really of what's affected, and a neuropsych eval can also diagnose. So as OTs, we can't diagnose. Primary care providers can use the information that we've gathered to inform a diagnosis as well, but sometimes it takes more of a specialist to be able to do that. And so I think it's often screening is the first step in determining that, and then in addition to looking at how someone is functioning, because there are people who have low cognition who are actually pretty functional with the supports that we give them. And so thinking about sort of these other factors, like if someone really is chronically drinking and that's resulting in very dangerous falls, in addition to all of these things, that's going to change it versus, someone maybe who's not. So.
Yeah, I think because we are able to work with our supportive housing program and because we also work with case management, when we get somebody who we have concerns about their cognitive ability, particularly with independent living, we get to help to inform decisions about where the client might be best able to live successfully in a safe way, because, things like, if their memory is impacted, risk for fires or losing their keys and getting access to, the building through whoever finds their keys, things like that. start to become a concern as well. So we want to set people up for the greatest amount of success, and sometimes we have the ability to also kind of influence where someone might be able to be housed or kind of help them along to find the best option for them.
Okay. So sometimes the cognitive and functional assessments can support paperwork to say this person requires assisted living care. You know, that sort of, because if people are able to do their ADLs, sometimes it's hard to, you know, if they're able, it's hard to advocate that they need a higher level of care. So looking at some of these more complex tasks, such as I can't manage my medication by myself, I'm not safe to cook, those are important considerations that might help a client get into a higher level of living care that you might not be able to see otherwise. So that can be.
I think when it comes to cognitive impairment, it's also really important to remember that sometimes you're seeing these what look like small deficits or small impairments, but with additional testing or screening, you might actually start to see those larger cracks. So I know that I've had clients that, you know, they're about to be housed and they come in for an assessment, and, you know, we've been using the MOCA scores, but someone's gotten a 12, which is a really not very good score. And so it raises some concerns. And then when you do additional functional assessment, starting to see that it might be a concern for somebody to go into the place that they are. And we've seen some clients not be successful with where they are housed because they present it in a way that does look much more functional and safe than they really are. So it really does come down, I think, a lot to screening and assessment to make sure that we're putting people into safe environments.
Right. Our clients are very good at covering and compensating, right? Because it's a safety issue. You can't look cognitively impaired on the street. That makes you a risk factor and vulnerable. And so I think because of that, our clients are not going to be forthcoming all the time with these struggles because they don't want to lose the opportunity or potential for housing, where they think they're going to be scolded for it. Like a client who missed his medication doses and then just dumped them on the counter at home and brought in empty pill boxes, right? Because he thought he was going to get in trouble for not taking them. Like, no, it's better that we know that you're not, you know. And so people can have those perceptions because of experiences that they've had. And so it does take sort of that observation piece and seeing people really do things to determine and say, hey, like Mara said, there might be things here that we're not picking up on because we haven't been able to see it otherwise. So.
And not to go back to the question you had asked previously about prevention of some of the behavioral components that can come with cognitive decline, but building that rapport and starting to build that relationship with our clients, I think, is really important because of the, you know, either mistreatment or undertreatment or, you know, abuse that they've gone through previously. Not all of our clients feel very comfortable within any kind of clinic or medical environment, and so if we can kind of encourage that rapport, build that trust, having the conversations that are often very tough with clients saying, we're not sure if independent living is great for you, or we're really thinking that assisted living is more appropriate, becomes an easier conversation for somebody else to hear because you've built up that sense of security and that sense of understanding with the person, that trust.
Yeah, I imagine that's a hard conversation to have, for sure. Annie has brought up a question about not having OTs or in their community or functional assessment screenings done prior to discharge from the hospital. So what's a way to either access occupational therapy or advocate for occupational therapists and for, I guess, functional screenings to be done as well?
Sure. Yeah, unfortunately, functional assessments really are very basic in the hospital setting because people are seen for such a short time that a lot of times OTs and PTs aren't able to do a full assessment like would be beneficial. Usually they're just looking at ADLs and not beyond that. So there are OTs everywhere. There's a lot of us. And there's a lot of OTs who are really motivated and interested in working with this population. So Mara and I are both involved with OTs and state and national organizations that if you're interested in figuring out who exists locally in your area, we're happy to sort of help with that connection. looking, depending on where you are, if there's an OT program, an academic program near you, they're always looking for community sites, especially with our population, because it's such good experience for students. And so they may be willing to do a partnership where, you know, they can do groups, they can do functional assessments under the supervision of a professor, because they really are, OTs are really interested in community and primary-based care and getting that experience. And so, and usually that then comes for free because you're doing a favor for the students. And so that might be a really good way to start, to kind of fit it into the program and say, hey, look at all this really good stuff we're getting just from these students. Wouldn't it be great if we were able to partner and have an OT part-time or full-time to do this, you know, a licensed clinician to do this more often with us. And so that can often be a first stepping stone, is working with a local school program that's there. But there are maybe OTs in the community that are willing to kind of work with you, do a consultative project of some sort. There may be outpatient clinics or home-based healthcare programs that you can partner with. It does take a little bit of advocacy about how respite care is different and how respite care helps our clients. So it might not be a good match every time you find the first, you know, an OT, but I think anyone who's interested in your population is going to be aware of some of these things that might happen. And I would say, too, sort of while that's happening, you know, finding a couple of your staff that might be interested in training in the cognitive assessment piece of it. You know, if you don't have resources for everyone to do it, even a couple of staff, that way you can at least screen people, even if you can't screen everyone, screening people that are demonstrating some of those deficit areas or functional problem areas, then you're at least getting some of that information to start out with. Yeah, there's a state licensure board and there's a state OT association for every state. And so if you're trying to figure out where these OTs are, that can also be a good place to start, because most of them are very active and can connect you with OTs who might be interested in that practice area or who are working in that practice area. OT not covered by local Medicaid? Of course not.
Are you able to bill for your services?
We were, and then they decided not to after we had been for years. So yeah, it's awesome. It's an ongoing advocacy piece. So it's tricky within the FQHC setting because there's not a strong precedent for rehab services within FQHCs. And so there's a way in some states that people will bill by like billing to provider using that billing code, which means like the person has to see another, like a physician that day to be able to get reimbursed for it. Otherwise, there's not really a consistent thing saying OT should be paid or not paid for their services. If you're not in an expansion state or you know that Medicaid doesn't cover OT, I think starting with a university program is a great place to start out then because they won't be billing for services there. And also just sort of thinking about if you're in any of the programs that, like a hospital partnership program, like to sort of reduce frequent flyers or like frequent readmissions, it may be worth negotiating with them to have an OT come and do some assessments with clients, because if you can prevent someone from having a fall, if you can improve their ability to follow medical recommendations or medication management, which are things OTs can look at and do, then you're not getting a hospital readmission, which most hospitals now are punished for having these frequent readmissions. And it's often people in poverty and with cognitive impairment that are being readmitted. And so that may be a way to negotiate and advocate too and say, hey, you have OTs on staff, can we get them 1 day a week to come, you know, do these assessments for frequently admitted clients or people that you're trying to manage more on the outpatient basis.
Great. Questions, comments, stories from your program, please share them. We're interested to hear. Another question for you guys, can you talk a little bit about supporting and preparing clients for when they exit respite? You talked a little bit about sometimes there being a struggle when things change or when things are new. So when somebody stabilizes in respite and then there's this disruption again of leaving the stable respite experience. So what can respite providers do to help people in that transition, I guess specifically people who with cognitive impairment?
I think starting with thinking about where the person is going most likely to go when leaving respite care, and that will inform some of the strategies that you might put into place. So if someone is returning, say, to stable housing, connecting with home health care is more realistic than if they're going to the shelter. Thinking about if the person, thinking a lot about, we always think about medication, but, does the person need weekly nursing medication adherence visits because they're sleeping on the street, they're not, necessarily demonstrating ability to take medication safely, versus we teach them how to use a pill box and how to fill a pill box and to call in for refills at the pharmacy. And a lot of it, I think, is teaching people who they can talk to when there is a problem, because you can't anticipate everything that might happen. And so when you're not a good problem solver, it's good for people to know what the resources are. If you have a problem with your medication, you can talk to the pharmacist, right? People don't know that. Here's where you can walk in if you're having a medical crisis that's not the emergency room. Like kind of giving people that information so that even if they can't figure it out themselves, they know where they can go to get help figuring it out.
And with our program, oftentimes you'll see, because our clients work with a therapist case manager while they're at a convalescent care program, when they're getting towards the time where they're being discharged, they're usually encouraged to start connection of care prior to leaving. So that way they get the familiarity, and they might get, an appointment or two, maybe even 4 or 5 with the provider that they're planning to transition to. So again, that repetition, that comfort starts to become a little bit more, or it'll hopefully help the transition, ease the transition so that it's not as disruptive, because, well, I was working with Sheila, but now I'm going to see Deb, and being able to transition that a little bit easier in their minds so that it's not an abstract idea. It's a very concrete, I was doing this, but now I'm going to go down to the clinic instead of.
Yeah. And it gives you the chance to, really facilitate it for clients. If it's a more complicated, I think that we're close to Johns Hopkins Hospital, which is the most confusing building ever to find your way around. So give an opportunity maybe for the community health worker or a peer support person to go with the client the first time to a chemo treatment, to their outpatient PT, whatever that might be, to help them navigate that initial intake and navigation process, which can be really frustrating and really hard to figure out. If you have paperwork, if there's a referral needed, if they want this information the person might not have, there's a support person to help even just managing the frustration of that, in addition to maybe providing some of the information so that people can get familiar with how it works and what they need to have with them when they go before they leave, so that they're more likely to follow up. Yeah.
Questions from the group? Got a quiet group today. Any experiences that the group wants to share from your program? It could be respite or not respite, or if you're developing your respite program.
I'm trying to think.
Another question I have is just around challenges for clients who are actively using or abusing substances, and how you really address that in your therapy.
I would say the first thing is don't assess anyone while they're intoxicated, because that's
a good suggestion. Yeah.
It won't be accurate. So I've had clients who have come specifically for their appointments to be assessed, and because they're intoxicated and have recently used, we just aren't going to do it that day. And so I think that's one place to start, is making sure what you're seeing is accurate. And people might present really differently some people are really, really functional when they're sober, and some people who use a lot are also not functional when they're sober. So I think it's making sure you're observing what's happening when the person's using versus not, because if they're not taking their medication every night, it might not be that they're forgetting, it's more that they're drinking instead, and maybe that's causing the forgetting, but the nights they don't drink, they take it. So a pill box is helpful, but really the barrier then is the substance use. So it kind of helps you, I think, prioritize where you want the conversation to go, and using some harm reduction approaches, right? Saying, okay, you keep forgetting your bedtime meds because you're drinking before bed. How about you take your evening meds at dinner when you're eating before you drink, right? Or making sure that they're not being prescribed medications that are going to conflict with ongoing substance use. Simplifying medication regimens, I think, is really critical for anyone, but especially cognitive impairment and substance use, so that people don't have to remember as much or learn as much or understand as much.
Can you share a couple of client stories of just people who have come through your convalescent care program that may either challenges or successes, maybe both?
Okay, on the spot. They're all composite in my head right now.
I can think of a couple of clients that I've had to have that tough conversation with, who are looking forward to moving into either their own room or their own apartment, and having the conversation that, making sure that you stay strength-based and focusing on the progress that they've made within the program, in the support they've received, the structure that they've received, and hey, doesn't it feel so much better that, you're able to talk to somebody when you need help with this, and haven't you been doing so great, you haven't fallen, and really highlighting the progress that they've made, and then starting to kind of build that on some of the support that they've been receiving, and say, wouldn't it be great if there was a place that was like this, that you could continue to receive that support? And having had a couple of people who have been very successfully placed in assisted living facilities and are still there and happy and healthy, is a really good feeling to say. It's a really tough conversation to have with somebody, but if you approach it in a very positive, encouraging way, and remembering that sometimes people, will need assisted living for 6 months until, again, things stabilize medically, and then they can transition out. And sometimes people are really just need the extra support, particularly when we're talking about, something that's going to continue to decline with time or with substance use or something like that. So I think those are some of the positives, or like the happy stories that can come out of screening and assessing early. And we've also had a lot of success when we talk to the people who are planning discharge from our program, and if that's the recommendation, sometimes people will stay at the program a little bit longer so that we make sure that they get into a quality place to, again, try and prevent any future issues or readmission to either hospital or our program.
And kind of allowing them kind of more autonomy then. If they're in agreement to go to assisted living earlier, then they can go look at a couple, right? And it's not sort of this placement of we're telling them you have to go here, but like making that choice together and building the autonomy so that, it's a smoother transition can be really helpful if we know, like Mara said, from early on. So,
and it can be tough because if memory is a problem, oftentimes you have to have this really tough conversation multiple times with a client.
Yeah.
Just kind of, again, continuing to reaffirm all the positive progress they've made, or any of the kind of difficulties that they might be able to identify in themselves, and really just sticking with it as one cohesive team really does help.
And I think opening up your encounters with the client with, hey, tell me what you remember about the last conversation that we had, right? Because that's a really good way. You're not saying, do you remember this, which people might cover and say, of course I remember, and not have any idea, but saying, tell me what you remember, or tell me about the last conversation we had, so that you're getting a clear sense of where the person is starting out the conversation. Because if you had this this tough conversation before, you think, okay, well, we've agreed to assisted living. I'm ready to jump in and look at them. If the client doesn't remember that or wasn't clear that that is really what the conversation was, they're coming in from a totally different place. And that's, again, when situations might escalate, because you're saying, okay, well, I have a list of assisted livings for us to look at today. And the client's going, wait, what, assisted living? I'm not going there. I'm going to live on my own. And then they're mad, and then that trust has been affected. So starting from the place of, you know, where did we leave off last time? Where are we starting today? So that you're starting where they are instead of starting where you are, because it could be vastly different. And we have the benefit of notes that we have to document, that we read before we see them, right? We don't have those. So our knowledge and awareness is going to be different.
We had mentioned a while ago about the embarrassment that sometimes people feel when they're having a hard time with their cognition. And I think there's something really great about making sure that when you're approaching the conversation with people, you know, I like to tell my clients, I know that we have good brain days and bad brain days, and everybody has those, and checking in with them first and letting them know that it's okay if you don't remember something, you know, and so normalizing it, saying, you know, there's no need, we need to be, you know, upset or embarrassed or frustrated with it. Like, I get it, it happens, let's work together to figure it out. And again, it really starts that conversation off on the right direction. So, you know, it all ties back to that prevention of behaviors that we don't like to see or are hard for us to manage. It all goes back to screening and awareness of when somebody is in that level of distress and they might not even know it, right?
And a lot of times when we've done the assessment, clients are actually sort of relieved to find out that there's a reason why. There's this sort of underlying reason, like, this is how my brain works. That's usually how I describe it. Like, everyone's brain works differently, and so we want to get a picture of how yours works and what's easy, what's hard for you. And people are often really relieved when there's sort of this, not even just number, but like, oh, like, this shows that really you do have a hard time with memory. And they're like, yeah, man, I really do. You know, that opens the conversations to strategies versus the approach of, like, why do you always forget your appointments? You know, that's going to open up a very different conversation, and people feel very validated when you identify, yeah, there's something else going on. And, you know, even just telling them, like, being homeless is hard. Stress is hard, and that's going to affect your thinking. You're not getting good sleep. Of course you're going to have a hard time concentrating. I think even validating the experience can be really, really helpful for people, and also a little bit hopeful. Like, okay, well, if this resolves, maybe it'll get a little better for me. You know, if I'm able to sleep 8 hours a night, maybe my memory will improve. And oftentimes it will a little bit, even if you still need some strategy.
Yeah. Staying strength-based and positive, right? Even if there is a cognitive deficit, there's a lot that we can do to help you still be able to do the everyday things that you want to do.
Great. Well, we're in our last few minutes here, so one last call for questions from participants. Get it in. We're almost at time, so if you have any burning questions, please add them. I want to just say briefly, too, like, it sounds like, I mean, we're working within a system that is not nearly as patient, I think, as a lot of us are or providers are. So I imagine that you're having to do a lot of advocacy for your clients as well within other systems of just explaining what's going on and also taking away some of the behavioral, like, this isn't a conscious decision to be obstinate or forgetful. Can you speak just very briefly, quickly about the amount of advocacy or where you feel like you're having to do systems advocacy for your clients?
Just about everywhere, I feel like.
Yeah, constant. I think especially with, like, sort of healthcare agencies that are not HCH, you know, people who are engaged with other services, you know, advocating about supports needed for medications, or if a client has missed a couple of appointments and they're like, oh, well, they've missed 3, they can't schedule again for 3 more months, being able to advocate for, like, okay, but now they're here in a respite care, we can facilitate them getting here, you know, let's try 2 more appointments and that type of thing. And that's not just us, of course, that's, you know, all of our respite care staff. So making that advocacy and saying, hey, give our clients a chance. We're here to support them and make sure that they're successful.
Yeah, great. All right. Well, I think we're going to go ahead and wrap up today. Thank you guys so much for being here. I just want to close. I first want to acknowledge that the coffee chat today was supported by the Health Resources and Services Administration. Participants, if you're interested in additional technical assistance on medical respite care or anything related to healthcare and homelessness, I encourage you to contact myself or my colleague Michael Durham. We're happy to help and support your program in any way that we can. A few reminders, registration is now open for our 2020 National Conference. It's going to be May 11th through 14th in Phoenix, Arizona this year, and we will be doing a full one-day medical respite pre-conference institute. Additionally, as part of the full conference, there will be site visits to Circle the City, which is the medical respite program in Phoenix. I highly recommend you attend the conference if you can. Additionally, we will be doing a second coffee chat, RCPN coffee chat in June of this year, and it's going to be on responding to ADL challenges in medical respite. So let's say you have somebody come into your respite program who you thought was independent in their activities of daily living, and you quickly realize that they are not, or that they need a higher level of care than what you provide. We're really interested in having an honest conversation about how programs are responding to that challenge, both logistically and then also ethically. So I hope you can join us for that. Finally, you will receive a brief evaluation when we close this chat. Please fill it out. We're really interested to hear your feedback so we can improve future sessions. This recording will be posted on our website soon. You'll get an email notification letting you know when it's live on the website. Again, thank you, Caitlin and Mara, for joining us and sharing your experience. We really appreciate you being here. Thank you to the participants, and you guys take care, and we will see you next time. Thanks so much. Take care, everybody. Bye. Have a good one.